Direct blow to the anterior pelvis commonly causes the following injury. A. Abdominal organ. B. Bladder. C. Open book injury. D. Sacral plexus. E. Ureter. And the answer is A. Abdominal organ. Now let's revise regarding the options of our earlier question. Pelvic fracture makes up about 10% of the fracture in blunt trauma patients. Over 60% of patients with pelvic fracture have at least one associated injury. The most commonly injured structures are intra-abdominal, with the liver, spleen, and kidneys occurring most often. Urogenital lesions account for over 40% of associated injuries. It is estimated that up to 24% of pelvic trauma patients have a ureteral injury and 20% have an associated bladder laceration. Most ureteral injuries in males are located at the bulbomembranous junction. 1 to 2% of traumatic rectal injuries are due to pelvic fracture. Vaginal lacerations are reported in 2 to 4% of pelvic fracture. The American Association for the Surgery of Trauma, AAST, divides the vaginal injuries into 3 degrees, 1 to 3. The first degree include contusion, hematoma, and superficial laceration involving only the mucosa. A second degree laceration involves deep fat or muscle. A third degree laceration involves the cervix or peritoneum or injury to adjacent organ. The most commonly injured arteries are anterior branches of the internal iliac artery, the superior gluteal artery, lateral sacral artery, and the pedestal and obturator arteries. The most common veins injured are the presacral plexus and the prevesical veins. Blood loss can also come from the fractured bones. The Young and Burgess classification consists of anteroposterior compression APC, lateral compression LC, vertical shear VS, or a combined mechanism CM. APC, anterior-posterior compression fracture, are the most unstable. These are the open book pelvic fracture. They are associated with pelvic and retroperitoneal hemorrhage. Lateral compression is the most common. These fractures are often stable, but can be associated with bladder rupture. Okay, everyone? Understand the answer? Which of the following is not a sign of an unstable scaphoid fracture? A. Vertical oblique fracture. B. Comminuted fracture. C. More than 1 mm displacement. D. Associated perilunate injury. E. Scapholunate angle less than 60 degree. And the answer is E. Scapholunate angle less than 60 degree. Now let's get to know a bit regarding the unstable scaphoid fracture. For scaphoid fracture, the diagnostic algorithm started when patients present with post-traumatic radial-sided wrist pain. 1. Anatomical snuff box tenderness. 2. Scaphoid tubercle tenderness. 3. Pain on axial compression of the thumb. There is a strong possibility of a scaphoid fracture exists when sign 1 or sign 2 or any combination of the signs 1, 2 and 3 are positive. Based on Martin Clemenson et al. 2020, they depicts an algorithm as the figure shows. Once they obtain the radiograph of the wrist and spatial projections of the scaphoid, if normal radiograph, they will proceed with a dorsal wrist cast and then MRI within 3 to 5 days. If there is a fracture detected on the radiograph, patient will be applied on a short arm cast and will be considered for CT investigation for this patient. Generally, signs of instability include: number 1, fracture displacement more than 1 mm. Number 2, DC, dorsal intercalated segment instability, whereby there is a dorsal tip of lunate. Number 3, scapholunate angle more than 60 degree. Number 4, lateral intrascaphoid angle more than 35 degree. Number 5, fracture combination. Number 6, scaphoid fracture as part of a perilunate injury. Okay, thank you. In Wartenberg syndrome, the compression takes place between A. Brachioradialis and extensor carpi radialis longus ECRL in pronation. B. Brachioradialis and ECRL in supination. C. ECRL and extensor carpi radialis brevis ECRB. D. Abductor pollicis longus APL, extensor pollicis brevis EPB, and ECRL, ECRB. E. Brachioradialis and flexor carpi radialis FCR. And the answer is A. Brachioradialis and ECRL, extensor carpi radialis longus in pronation. Now let's get to know a bit regarding Wartenberg syndrome. Chiralgia paresthetica means hand pain, superficial radial nerve palsy, or superficial radial nerve compression are synonymous with Wartenberg syndrome. The superficial branch of the radial nerve is purely sensory nerve, which is a distal branch of the radial nerve. Regarding the cause of radial nerve, in the upper arm, the radial nerve traverses behind the humerus, wraps around the humerus laterally, and then crosses anterior to the lateral epicondyle of the humerus in the antecubital fossa region, where the nerve will be divided into posterior interosseous nerve, is a motor branch, and superficial branch, a purely sensory branch. The superficial branch runs superficial to the supinator muscle and then along the ulnar edge and deep to the brachioradialis. This picture illustrates the simplified view of the cause of the radial nerve. About 9 cm proximal to the radial styloid, the superficial branch of the radial nerve become subcutaneous between the brachioradialis and the extensor carpi radialis longus (ECRL). More distally and in the forearm, the nerve divided into branches, providing sensation to the dorsal radial aspect of the hand, dorsal aspect of the thumb, the index and middle finger proximal to the distal interphalangeal joint. This picture illustrates the cause of the superficial branch of the radial nerve at the wrist and the hand region, especially the thumb, the index and middle finger. The nerve travels from a deep to superficial location. It is particularly vulnerable to compression from the edge of the brachioradialis. Dallon and McKinnon stated that the site of entrapment is the area where the superficial branch of the radial nerve transitions from the submuscular to subcutaneous between the fascia joining the brachioradialis to the extensor carpi radialis tendon. The symptoms and signs of Wartenberg syndrome: pain, paresthesia, and dysesthesia along the dorsal-radial distal forearm extending into the dorsal first web space and thumb. The exact area of symptoms can vary. The overlapping pattern of innervation of the superficial branch of the radial nerve and the lateral antebrachial cutaneous nerve can result in variation in sensory findings. There is variability in the digital innervation of the radial sensory nerve. Positive tinel sign is elicited when gentle tapping over the superficial branch at the radial nerve in the mid-forearm distal to the brachioradialis muscle belly. Sensory abnormalities are often detected on examination on the dorsal radial aspect of the hand. Forced forearm pronation and forceful hyperpronation of the forearm with ulnar deviation and flexion of the wrist can provoke the symptoms. Okay, thank you.